So welcome back to the Dr. Doug Show. Today we're going to do an AMA, an Ask Me Anything style podcast. We've struggled over the last several months now to be able to keep up with comments on YouTube. And you probably noticed that there's comments that are going unanswered. And that's because we simply don't have time to answer all the comments. We love them. Please ask them. The community actually answers a lot of them for us. But from my perspective, I want to answer the ones that I think are most impactful, the ones that are not answered multiple times in the thread, and bring these forward because these are great topics. We love the questions on YouTube. So again, keep putting them in there. You'll get hopefully some answers from our community members, and then also I can bring them forward in an AMA. And we're going to start doing this probably monthly. So I'm going to run through the probably top 8 or 10 questions here. Hopefully these will make sense to you. We'll actually have them listed in the description, so you could potentially fast forward to the one that is most pertinent to you. So here we go. So the first question is about drugs. And the question goes like this. My doctor put me on Evenity and I'm 53 years old. How does my life look as far as having to take medications in 10 years? Can I ever go off of them? So this is a really common question because we see younger and younger individuals, both women and men, but especially women around menopause who are getting screened because they should get screened to have this conversation. But then the challenge is you get a diagnosis and your doctor generally only has one tool, and that's pharmacologic therapy. So the question is, which drug are they going to recommend? And the question that most doctors are not answering and most patients are not asking is, how long do I have to take this drug? Can I ever come off of this drug? What does my life look like in 10 years? Am I still on a drug? And this is absolutely the question to be asking. So I don't know anything about this person's case, so I don't know if they're really a good candidate for Evenity, which is someone who has severe fracture risk. Did they just want Evenity because they don't like bisphosphonates? I just had that story recently from someone in our community, the Osteo Collective. So I don't know the clinical case here. But what I can tell you is if you look at the guidelines around osteoporosis and around drug therapy, the recommendations are to initiate therapy if you have adequate fracture risk. And that could be osteopenia or low bone density and elevated fracture risk as based off of Frax. Or it could be a diagnosis of osteoporosis. Then by definition, you are a candidate. You meet the indications for pharmacologic therapy. Here's the thing, and I just did a video on this recently. Bisphosphonate drugs, you've got a range of around 3 to 6 years of which you could take this drug. Prolia, we have safety data to 10 years. Evenities, 1 year. The anabolic drugs, Forteo, Tymlos, those are 2 years. This person's 53. So what is the long-term plan here? I can tell you that most doctors will talk about using an anti-resorptive drug like a bisphosphonate for 3 or 6 years, and then you take a drug holiday and you monitor your bone density over time. But what I can tell you if you look at the studies is that the bone density will start to go down because you never learned what the underlying issue was in the first place. That's why I tell people who are even going to go on these drugs, I say, look, that's fine, go on the drug if it's right for you, but still develop a comprehensive plan around your bone health, because if you don't have that, then you can't come off of the drugs without anticipating that you're going to lose bone. We see this with the Prolia data. If you take Prolia in the Freedom Extension trial, you come off after 10 years, those that came off were more likely to see repeat fractures, spine fractures, multiple vertebral fractures. So we know that this happens, especially in Prolia. We know that you can't stay on the bisphosphonates forever, and the anabolics just aren't an option for long-term care. And usually the anabolics are done before the anti-resorptives, and then you are back stuck in the same anti-resorptive game. How long do I do it? When can I come off? How do I come off? So for us, we see patients that are on these drugs. We develop a comprehensive plan. It is possible to come off of these drugs, not use another drug, and not lose bone, but it has to be done right. And most doctors are going to tell you that this isn't possible, but I can tell you clinically this is what we see. Because if you think about most of the studies, they're using the drugs as an intervention. It's the only thing that they're doing. So again, it makes sense that if you remove that intervention, they're going to lose bone because they were losing bone in the first place. Right? If nothing else changed, why would it be any different? If you change the underlying bone metabolism through exercise, through nutrition, through better sleep, through reductions in stress, through the right supplements, maybe HRT, if these are the tools that you can use, and you put all these things in place, then there is a chance that you can improve your bone metabolism enough that you don't lose bone. But please hear me when I say this. I am not telling you to come off of your drug and not follow your doctor's orders. You have to do this unless you have another plan with somebody who is helping you do this correctly, because you have to monitor your bone quality, your density with labs, with repeat imaging to know that you're not rapidly losing bone. Otherwise, you could be put into a dangerous place. So this is a really challenging conversation. And the conventional medical model would say that, yes, you have to consider some kind of pharmacologic therapy indefinitely because they do not have enough evidence around the tools from their perspective, around the other tools that are going to help you to lose bone. Doctors are hesitant to use HRT as a tool, and I can tell you it's a powerful tool. But the doctors that are treating bone health are generally not the doctors that are using HRT, and this is a big disconnect. So kind of a long answer, but this is a really important topic. All right, so this next one is around the supplement DHEA, which is an over-the-counter supplement in the US, actually is prescription in other countries. And the comment goes like this. Please comment on the effects of bone health with the use of DHEA. The American Urology Association, the AUA, recently added this to their guidelines. And what they recommended, just paraphrasing here, is that you can use DHEA vaginally to help with symptoms of GSM, genitourinary syndrome of menopause. So her question goes on to say, it's been found to improve symptoms of vaginal and urethral dryness, improving sexual health, and decrease urinary tract infections. Are there any studies indicating improved bone density with the addition of DHEA? The answer is yes, but let me talk about the stem first. So absolutely, the vaginal tissue, especially in the lower third, is very responsive to androgens like DHEA. This is why it works so well for all those tissues and again, the lower third of the tract. So that's going to include the urinary tract. It's going to include the internal and external vagina, again, there by the entrance. And DHEA then is a powerful tool that is underutilized, I think, for that case. A lot of women are using estradiol or estriol, and that is also impactful and helpful. Certainly could also use those things. A lot of women, so our patients are using them both. So then what about bone health? Well, from a bone health perspective, there are studies on DHEA. They're not perfect though. They did use DHEA in a randomized control trial and it did show improvement in bone density. So that's awesome, except that the dose they used for women was 50 milligrams, which is a really big dose. So from a 50 milligram dose, if you're not using it with something like saw palmetto or something that's going to block 5-alpha reductase, which is going to convert testosterone to DHT, there's the concern for androgen-like symptoms. So that would be like potentially hair loss, oily skin, acne. So 50 milligrams is a big dose for women. I don't have very many women that can tolerate that big of a dose. And then in men, they used a 100 milligram dose, which again is a massive dose for men. So this is the challenge with the research around DHEA for bone health. It exists, but would we see the same impact with 10 milligrams or 20 milligrams? And we can't say for sure that we would. So we do use it from an androgen perspective, especially for women who need some androgen support who aren't on testosterone. What is it actually doing for bone? We don't really know.
All right, sorry to interrupt this video, but I want to take a moment and talk about this product by 4Well. It's specifically a product utilizing DHEA, saw palmetto, and collagen all together in one. And the reason why I want to talk about this is that you may have heard me discuss DHEA for bone health. In the videos that I did on this topic, DHEA is an interesting pro-hormone that's available over the counter, and it has been studied for bone, but only in what I think are relatively big doses. So 50 milligrams for women and 100 milligrams for men. The challenge here is that if you use these doses of DHEA alone, clinically, what we saw is that women were complaining about oily skin, acne, and potentially even hair loss. So we backed that down and now in our clinical practice use doses between 5 and 20 milligrams. But there are ways to utilize larger doses and potentially even have a positive impact on your hair. And what they did in this product is specifically use things like saw palmetto and collagen to help block the conversion of testosterone to dihydrotestosterone and also provide your hair some of the building blocks that it needs through collagen. So let me explain. This product uses 50 milligrams of DHEA, which again is the dose that was studied, but adding in 500 milligrams of saw palmetto and 350 milligrams of collagen. Now, the saw palmetto is interesting because this is an herb that uses the same mechanism as finasteride, which is a well-known and well-used hair loss drug. It helps to improve hair loss in both men and women. Now, this enzyme is responsible for the conversion of testosterone to the more active androgenic form dihydrotestosterone, particularly in the periphery, meaning in the skin. So it can actually have an impact on hair. And so we see this both with finasteride, but you also see studies seeing it with saw palmetto too. Now, the collagen is actually here to provide the building blocks. And we know that collagen in different forms and different doses can be good for our skin, hair, and nails. I don't think anybody's disputing that. But when you combine all three, what I think is really compelling is you can take DHEA at higher doses for people who are sensitive like I am. And I've been taking the men's version of this product, which has 50 milligrams of DHEA, which I would not have been able to tolerate alone, and I've not had any androgenic side effects whatsoever. So if you want to check out this product called Advanced Formula Saw Palmetto for women, this is by the company 4Well, and you can take a look at their Amazon store, look at the link in the description here on YouTube, and use the code Dr. Doug 4Well. That's DRDOUG, the number 4 and Well, WELL, and you'll get 10% off of anything in their inventory.
All right, this third question is about TRT. So the question goes like this: does taking flaxseed or soy have any effect on men who are on TRT? So it's kind of a challenging one. I've not seen these two things studied together because TRT is just relatively understudied in general. But if we think about this from a physiologic perspective, let's think about it this way. Testosterone replacement therapy, TRT, is adding a significant amount of androgen or testosterone directly to the system. Exogenous TRT through either, capsule, through Kaisertrax, or injection, or for some people, a topical cream. When you do that, you're kind of overriding all of the other potential inputs. So would soy have a negative impact on TRT? I wouldn't think it would have a significant impact. For men who are on, let's say, a lot of testosterone, they need a larger dose to improve their symptoms, and they have relatively high levels of estrogen as a result of that. Is this a compounding effect with flax and soy? I don't know. Again, hasn't really been studied. But I think the big picture here is this. Why are you taking a lot of flaxseed and soy? So flaxseed has some potential benefits for sure. So there's the fiber piece and there is the estrogen side piece. But if you're on TRT, you actually don't need more estrogen as a guy. If you're on adequate TRT, it's going to convert through aromatase into estradiol, and that's going to give you all the estrogen you need. So if you're taking flaxseed or soy for the estrogen effects, you don't need it. If you're taking soy from a protein source perspective, I don't recommend soy all day, every day as a protein source. We need to use better quality sources. If you're open to using animal products, absolutely, animal products are going to be better than soy all day long, every day, in my opinion. Could you mix and match plant sources of protein? For sure, and lots of people get away with this, and they can do it if you can tolerate the additional calories, carbohydrates that come along with plant sources of protein. So I hope that helps. All right, so this next question is about DEXA. So let me read the stem here. It goes like this. I was recently diagnosed with osteopenia at age 53, also called low bone density. Her femoral neck T-score, assuming this is a woman, was negative 1.6. Z-score, negative 1, doesn't matter. My biggest question is, how come my spine is in excellent condition, T-score is 0.9, and why is there such a huge difference between my femoral neck and my spine? So we get this question a lot, right? So how come there is a discrepancy between different body parts? So I'm going to say her scores again. So T-score negative 1.6 in the femoral neck, so that's the hip. And then in the spine, it was positive 0.9. So we are talking about a gap there, which is relatively big, right? Let me just talk a little bit about T-score and Z-score. So when we're talking about women over the age of 50, we're going to look at T-score only. We don't need to worry about Z-score. We worry about that in younger adults when we're comparing to age-matched individuals. When we're looking at women over the age of 50, true for men, some people would say 55, but when you're looking at the population that is not young adult, we want to use T-score because that's the diagnosis of osteoporosis according to the World Health Organization, Bone Health and Osteoporosis Foundation, et cetera. So we want to use T-score, not Z-score. So you can ignore your Z-score, okay? So we know that osteopenia is a diagnosis with a T-score of negative 1 to negative 2.5. So she is correct that a negative 1.6 puts her in osteopenia, or again, low bone density. Anything above that is going to be above the median because T-score is just a standard deviation of the mean, of the average for your gender, your sex, and for your ethnicity as it's listed out there. So if you are a Caucasian female, you're going to have a different range than if you are an Asian female or a Black female. So it is specific to your sex, it is specific to your ethnicity, okay? So then the T-score is just simply a bell curve. So if you are negative 1, you are 1 standard deviation below for the population of interest. If you're negative 2, you're 2 standard deviations below. Negative 3, 3 standard deviations below, okay? So then again, negative 1.6, you are about 1.5 standard deviations below the mean. Okay, so that is, again, low bone density. If you're 0.9, you're almost 1 standard deviation above the mean. So that is a difference of almost 2 standard deviations. And that is what's called discordance. We see discordance more in DEXA than other modalities like REMS and on CT. Discordance means you are more than 1 standard deviation away. And in this case, this is a large discordance of almost 2 standard deviations away, or almost there. So when we see discordance, the concern is that one of those scores is not correct, because unless you are immobilized in some way, you shouldn't have osteoporosis of one body part and normal bone density in the other. You should not have 2 standard deviations separating the two. So this is where we have to get into kind of some of the nitty-gritty around DEXA. DEXA is not perfect by any means. DEXA is sensitive to and may be inaccurate in some conditions, as in rotation of the spine, malposition on the table, arthritis of the spine. So it could make your spine look better than it is if you have those things. And then again, positioning of the femoral neck could change the T-score there. There's other variability or variations from machine to machine, interpreter to interpreter. So DEXA just leaves a lot of room for variability. That's why we have this thing in DEXA called the LSC, or the least significant change. And I won't describe that in detail now. So anyway, when we see large discordance like this, what I say is one of these two is probably not accurate. We probably need to either repeat the DEXA, try to get a REMS, but also realize that it kind of doesn't matter too much, because we know that you probably have somewhat low bone density in your hip. So if you have low bone density in your hip, you probably want to do the things that are good for your bone. And those are also going to be the things that are good for your health span anyway. So you could take this as a blessing to say at 53, you learned that you might have low bone density in your hip. Sure, let's get some additional information, but let's learn the things that are good for our bones so we don't keep losing bone as a 53-year-old female. So this will be the last one that I do. And this is a good one around HRT from a global perspective. So this one goes like this. In Australia, we're told not to take HRT longer than 5 years. If, when you stop it, your bones just get worse again, what's the point? That's a good question. So we still see some of this dogma and this mindset in the US as well. There was a time and a place where doctors were told for patients, when we're talking about HRT, to use the lowest dose for the shortest period of time to reduce the quote unquote risk. So we don't say that anymore. And now there is not, in the US with the guidelines, there is not a clear recommendation on when to stop. So this has sort of gone away in the US, and I haven't looked at Australian guidelines, but I would assume that hopefully they will get there soon if they're not already there, and this doctor just didn't know it. But there was a study that just came out recently that showed that even in short-term users of HRT, the long-term protection on your bone is still actually better than if you never took it. So even if this was true, you're still better off using it for this short term, for 3, 4, 5 years, and then coming off of it, there is still a difference in the trajectory of the likelihood of fracture. So it's still better. Now, long-term use better, and this is what I generally recommend for my patients, long-term use better, indefinite use likely even better. Now, what this study actually also showed is that there is a brief increase in the risk of fracture right when you come off of HRT. I think that has to do with the people that were using it that weren't doing anything else and that were at high risk of fracture anyway. But you can't ignore the fact that that blip did occur. So this is, something that people have to talk about with their doctors. My recommendation is this is going to be protective of bone. If you have low bone density or osteoporosis, this is a powerful reason to continue to use HRT over time if you can tolerate it, if you don't have reasons to come off. So this whole lowest dose for the shortest period of time, that is symptomatology. That's menopausal hormone therapy, which is the idea of controlling the symptoms of menopause. That's not what I'm talking about. I'm talking about using hormones for the things that they're good for. So that could be prevention of osteoporosis, as FDA approved in the US. That could be for reducing the risk of cardiovascular disease, as we see in numerous studies if it started within 10 years of menopause. Potentially even protecting your brain, TBD on some research coming out on that, seems to go both ways. But it seems to be that if we are using hormone therapy to improve our cellular function, our metabolism, reducing our risk of diabetes, improving our bone health, maintaining our muscle mass, reducing our visceral fat, boy, it seems like it'd be good for just about every body system, doesn't it? So anyway, I think that this idea that we need to stop after 5 years it should be gone. There's no evidence to support that. Risk does not increase of anything if you stay on it. In fact, the risk of mortality continues to decrease the longer you stay on it. So hope that helps that question. All right, so that's it today. If you found this helpful, you might want to consider coming to our masterclass. So our masterclass is something we run about every week. I go through the top 5 mistakes that we see people make on a regular basis in their bone health journey so I can help you time collapse your journey to bone health success. If that's of interest to you, look for the link in the description below. We also do a Q&A in that masterclass. So if you want to ask your question to me specifically, then go ahead and sign up and make sure you drop your question in the Q&A in the masterclass as soon as you hop on so that when we answer them in order, you can get your question answered. That's how we're doing it now, at least. All right, hope that helps. Again, link in the description on YouTube. Go to our website, osteocollective.com, and you can sign up for it there as well. That's it for today. So please remember that life is about honoring your health, creating memories, and aging with strength and grace.